Thank you all for having me. First off, I'm Richard. I'm the relationship manager here at Patient Advocate Foundation. And that is just a fancy title they've given me for saying that I talk all day long. We were founded about 30 years ago by Nancy Davenport Ennis and her husband, Jack. So Nancy is an incredible 2-time breast cancer survivor. She was a school teacher before she came on to do Patient Advocate Foundation. During that time, Nancy had started her treatment, had been in remission for breast cancer, and she had a friend, Cheryl, who was diagnosed with breast cancer. So as all good friends do, Nancy was able to provide Cheryl with some guidance, kind of the best course of action. Got Cheryl hooked up with some treatment at Duke in North Carolina. And this was the mid 80s. So if we go back in time, it was big hair and it was before me. So Cheryl was in treatment, and about halfway through, her insurance came back and said, oops, we've made a mistake. So, if you want to continue this treatment, which will prolong your life, you're going to have to come out of pocket about $20,000. So it was the mid 80s. It was before GoFundMe. It was before any of that. So it was bake sales. It was second mortgages on housing. And thankfully they were able to raise that money, and the treatment to go on to prolong Cheryl's life for years and years. She was able to see her kids graduate. It was great, but it just didn't sit right with Nancy. So Nancy had told this friend, that this is what she should do, and it caused all these problems. So Nancy went to the insurance commissioner here in Virginia, where we're located, and said, this isn't right. How can this happen? This person has, a right. And was essentially laughed out of the office, was told, if you don't like how this is, you're going to have to change the law. So that's what Nancy did. She went on to change some insurance access laws here in Virginia in the mid to late 80s. At the time, the Washington Post picked up the story and was like, there's the school teacher taking on big insurance companies. So thankfully that kind of launched Nancy and got her in front of some other states. And she went on to pass laws in dozens of other states. So cut to 1996, Nancy founded Patient Advocate Foundation. We had a volunteer staff of 2, and now 30 years later, we've got a full-time staff of just over 220. So we've grown quite a bit in our 30 years. So kind of how we assist patients. So we are not disease focused. We are focused on relieving and removing barriers to care. And we do that through these eight different core, focus programs. And we are located in Virginia, but everything we do is over the phone or online. So we are in all 50 states and territories. Just last year, we assisted a patient in 91% of all U.S. counties. So, maybe one day we'll get to 100. But so just kind of going into our programs, I'll touch on them a little bit. And then at the end of each one, I'll ask if anyone has any questions, because they all kind of operate differently and they all kind of have a different focus. So our first program we ever created, why Patient Advocate was founded, is our free case management services. Our case managers will work in a bunch of different ways, but the main things patients call us for are health insurance navigation, disability navigation, and for financial hardship support. So what our case managers are able to do is work with patients to overcome insurance, whether it's an appeal, a denial, a prior authorization. We work with a lot of billing issues, helping patients that have insurance that want to change to a different insurance, or if they're going from able to disabled, going through the disability process, Medicare, Medicaid. We help patients with marketplace plans, kind of helping patients fill out forms, alleviating some of that burden of having to sit online all day and fill out forms, or call an insurance company and be online for, on the phone for 3 hours. That's kind of where our case managers live and work, in that space to try to help remove that. We also do a lot of financial hardship. So we have some financial assistance that we provide in-house, but that's never good enough. So we also try to connect patients with anybody, whether it be national, regional, state level, community-based organizations that are offering assistance. We look as far and as wide as we can, because we feel that just providing financial assistance from us and then moving on isn't enough. So we have to have that interconnectedness of working with other programs. So we do work with patients to try to get, even if it's non-medical, if it's housing, transportation, utilities, we do a lot of that work as well. I don't like to talk numbers a lot just because it feels kind of like I'm teaching, but I do like to point out a couple of things that our case managers do. So in 2024, my big one and my favorite one is going to be that we were able to obtain $17 million in debt relief on behalf of patients. So that is, calling hospitals and negotiating bills, that is finding billing mistakes, you name it. So 17 million obtained just last year. And I also like to highlight that our case management isn't just a quick fix. We've learned over the years that programs problems are really complex. And that can be seen here by our average number of contacts to resolve a case is now up to 30. So that's 30 phone calls or emails, talking with insurance, talking with doctors. I'm sure all of it seems like every year things get more complex. The systems in place take longer. And that kind of is what we're seeing as well. So sometimes we'll be with patients for, 30, 60, 90 days, 18 months. It depends on kind of what we're working on, how complex the issues, how many are at hand. And again, we do that for any diagnosis. We help anybody with any chronic, debilitating, life-threatening illness. So that's just a nice way of saying we help everybody. The things we don't do is we don't do things like workman's comp, car crashes, and medical malpractice. But anything else, that's kind of where we are. We assisted patients in over 800 different diagnoses last year alone. And it doesn't just have to be one or the other. Most of 13% of our patients report multiple diagnoses, and we work with that as well. So that is our case management program. It's one thing to assist patients. It's another thing to help them understand the processes. So I don't know where everybody here went to school, but I didn't learn what an EOB was. I didn't learn what a deductible, a copay. None of that is taught to us. It's something we're expected to know. We get handed paperwork, and that's kind of where we start. So what we've started doing over the years is listening to the patients that call in through our copay number and kind of taking what we're doing and making educational pieces out of it. So again, most of them are non-diagnosis specific, but they do touch on things like appealing a denial. So it's something that we can do in case management, but it's also something that we teach how to do. So we have sample appeal letters so that you can download the letter, just plug in your information and send it out. We also get into things like, what is health insurance? What are the changes to Medicare? Why should I do clinical trials if I'm interested, and what goes along with that? We also can get into some pretty niche topics like what's a biomarker testing and why does this research matter? But we also do a lot of financial literacy and just helping with those core issues that patients are facing when going through the healthcare system. We also make it all publicly available on our website. So one of our most used tools is our financial resource directory. So I like to tell people to ignore the financial part. It was originally created to be a tool to connect patients with other organizations that were providing financial assistance, but we've since grown it to include resources for like support groups or clinical trials or, disease specific education. So since we don't provide any, what to do after you're diagnosed with a certain disease, we like to link to other organizations that provide really good information on the topic. So it's a free tool on our website. It has thousands and thousands of different resources on there. You can filter it by insurance, age, what state, what diagnosis, and then what assistance type you're needing. So you can say that I have cancer, I live in Alabama, I'm 40 years old, and I need help finding a support group. And it'll populate a list. The list can be printed out or it can be emailed from our website. So if you want to email it to yourself, want to email it to a friend, if you're a caregiver and want to send it, out, you can. And so that's a a really nice tool that we now have. We also have a Medicare Resource Center website that's dedicated directly to the changes going on with Medicare, the Inflation Reduction Act, and anything that's being changed to follow it. Depending on how things go, we update the website frequently so that it's easy to understand and digest, what's going on. And then we've also projected out with what the changes are expected to be in 2026, 27, 28, and so on, because some of those were a tiered rollout.
Someone's asked, are there resources only for newly diagnosed patients, or is this for all patients?
Yeah, it's for all. So, we've had patients that have been on our programs for 10, 15 years, and our resources reflect that. So you may have some now that are newly diagnosed, going down if you're trying to get, you get on disability. We have publications that go into how to get the most out of your benefits, because you will be given a lot of benefits, but you won't always be told that you have them. So it kind of breaks down how to get them, what you're eligible for. And then it goes into, if you want to start a clinical trial, you've tried treatment and, you think clinical trials are right for you, you can do that. We also have some, you're in remission, but you're still, you've paid all of your medical bills, and now, it's time to pay the mortgage, and, you come up short. So we have some tip sheets and long format guides that kind of go into best practices, how to overcome some of those obstacles. So it really spans the whole patient journey is what we try to do. And now, it's 500 plus at this point. So it's pretty intense, but it's by no means comprehensive. As we all know, different needs are arising every day just based on everyday life. But yeah, and I'll touch that. A lot of them are English, Spanish. A lot of them now are in American Sign Language. We try to do them in different formats. So we have some when you get into Medicare that are like 30-page books, but we also have some that are just one page. So easy to digest. We try to write everything to where if you've never even heard of insurance, you'd be able to follow along. And then a lot of them are just being translated, or not translated, but being transferred into audio format. So, if you're driving, you don't have the time to sit down and read a book, we'll be able to provide that in an audio format too.
That's fantastic. Well, do you also have counselors that for instance, at our Charlotte meeting yesterday, we have a patient who has to make a decision very quickly as whether or not she wants to go on to disability. And so could we refer her to you guys for counseling as well as the resources?
Yeah, definitely. So that's perfect for our case managers. They would be able to, on the first call, they do kind of a big picture assessment to see what all is going on so that they can start pulling in resources, whether it be educational or, a list of potential things that need to be done as far as filling out papers or talking to different organizations, different government assistance, things like that. So yeah, that would be kind of our bread and butter.
Perfect. And then I've seen some comments before, but in addition to the one I'm looking at now, asking about how patients learn about you guys. I know someone in our group here said that they found you while doing an internet search for financial resources for cancer patients. But what about our nurse navigators and our social workers? Are they're very familiar with you guys? And if not, we will make sure they are the ones that we work with. Is that who do you guys usually work with in terms of?
Yeah, so we work with anybody that is on the patient side. So we work with the patient, a caregiver, a family member, friends. We work with doctors' offices, social workers, nurse navigators, resource specialists. We also work with pharmacies to some extent that the pharmacy has staff available. And I'll get into it a little bit here, but we also just recently launched a nonprofit portal. So we've always had our patient, provider, and pharmacy portals, and that's great if you're connected to a specialty pharmacy or, a health center that has somebody that is, has a social worker, has a resource navigator. But what we were finding is this was we are a nonprofit and we could not, our own case managers didn't have the ability to go to other nonprofits and use their portals. And so we thought if we're having this problem, obviously a lot of people are having this problem. So we created a nonprofit portal, which is more comprehensive than any of our other portals. So what it allows people at nonprofits to do is use their tax ID number to create an account. And that portal will link to our education department. It'll link to our case management department. It'll link to our copay, which I'll get into here in a bit. And it gives you our full resource library for all of our resources and our educational pieces kind of right there. You can print them off, you can download them. So yeah, people find out about us mostly word of mouth. For 30 years. We don't spend money on advertising. We have some in-kind earned media that a marketing agency will donate occasionally, but we tend to like to give all of our money back to patients and put in back into those programs. And we find that spending a lot of money on, ads isn't the best use of our resources. So yeah, it's things like this. That's why I talk all day. I reach out to patients, providers, nonprofits, just kind of sharing that information and hoping that if somebody finds it useful, they'll share it when they need to.
Wonderful. Thank you. Well, you all have a task now put in front of you. Share this information. Okay. That's all I have in the chat right now, Richard. So if you want to go right ahead.
All right. Thank you. So I will get into what we are asked about the most is our financial support programs. So I will start with our copay relief program. There are several copay relief programs around. Manufacturers do their own in-house. Most of the times those omit Medicare and Medicaid patients. And there's a couple charitable ones around as well. We're the second oldest in the country, and we were the first one to do multiple different diagnoses. So again, I don't love doing the numbers, but I do it just because. So we distributed last year a little over 200 million to patients through 60 different disease funds. And I like to point out the 190,000 incoming calls last year, just to let everybody know that it is a busy program. We do take a lot of calls, but we also have an online portal as well. So what does this look like for those that aren't familiar with copay assistance? I'm sure most of you are. It is a grant that we give out to help with everything prescribed for a diagnosis. So how we operate is based on the diagnosis. It doesn't favor a drug, treatment, a brand. We try to be all inclusive if we can be. So the income requirements are relatively simple. They're 500% of the federal poverty guideline for most of our funds. And so we do that based on zip code level. So I know the national level is around, I think it's a little over $70,000 for one person at 500%, but we don't like to go by that. We like to go based on where patients actually live. So we obviously know that you go to one zip code, in rural Alabama, the cost of living looks completely different than if you were in Los Angeles. So that's why we use zip code level, because it kind of levels the playing field. We're not just saying blanket statement, you have to make this. So we go by the zip code level, and then we go by the amount of people in the house. Obviously, if you've got 8 people in your house, your cost of living is going to look a lot different than someone that only has 1. So that's why we do that. We do verify a diagnosis. So we handle that for you. We don't ask you to go to your doctor's office. What we do is we reach out to the doctor's office. It's normally still by fax, but we will get them a diagnosis form, and then all they have to do is confirm that yes, you are being seen for that diagnosis. And then because it's a copay program, you do have to have insurance. So in order to get to a copay, you have to have insurance. But kind of going with what the insurance is provided, our copay program pays for insurance premiums in a lot of our funds. So that can be your Medicare Part D, that can be your Medicare Advantage, it can be your marketplace plan, your commercial. We can either, we can reimburse you for your monthly premiums. And then we also, again, we do what's prescribed to treat the diagnosis. So not only are we covering like chemotherapies or anything, but we also will cover anything your doctor writes for it. So if you're prescribed an antiviral, an anti-nausea, a sleep aid, something to help with appetite, something to help with your tummy, something, to help with pain, those are also considered as part of that. That way we're helping with the full full diagnosis. I mean, there are some things that aren't, if you're approved for, head and neck cancer, it probably isn't going to cover your insulin just because that's, not completely related, but we do try to be as broad as we can. The other thing that we cover is administrative charges and office visits for treatment. So if you do have to get something injected, you have to go for that. We won't just pay for the medication. We'll also pay for the administrative fee and the office visit. That way, it covers the full scope of that visit. And then just kind of some of the details. So we operate on a first come, first served basis because we feel it is the fairest. We don't operate on a wait list model just because we've seen over the years if some patients are connected to a specialty pharmacy that has hundreds of people sitting at a call center, they can just bulk put in every single patient that they have in a list. So that means when that fund opens, if we were on that model, all of those people would get in first because they were lucky enough to be connected. So we find that to be unfair. So we do go on a first come, first serve model once the fund opens. It is on a rolling 12-month period. So we don't go from January to December. If you're approved today, you're approved today through today for next year. We do have a look back period of 6 months. So we know that over time, patients don't always find us right when they're diagnosed. So we go back 6 months and try to help reimburse for those retroactively. We also have a 2-month grace period. So at the end, once your award expires, you have 2 full months because we know sometimes insurance can be slow getting those bills out. We allow for that in that. But we do have a 120-day utilization requirement. This is just so that patients or pharmacies or providers don't apply somebody and we set that money aside for them and then it's never used. This makes it so where we can, if it's been 120 days and no one's gotten a medication, then that needs to go to another patient that is getting medication. And then, if funding is available, we allow for reapplying for as many years as needed. For applying, the application process is really simple. It can be done online or over the phone. Again, we have patient, provider, pharmacy, and nonprofit portals that are available. It's an instant decision process. It takes probably less than 10 minutes. And then we verify income electronically, just so, again, it alleviates that burden of having to mail out or fax in, a whole bunch of bills and statements. And then like I said, our diagnosis is simple. We do it on the back end. We'll reach out to the doctor that you say that is treating you, and we'll get that information again, so you don't have to worry about that paperwork. Our portals are open 24 hours a day. Our toll-free number is not. We're Monday through Friday. We're closed most major holidays. And then again, it's instant decision. So if you were approved today over the phone or online, we can give you a pharmacy card right now. A lot of our calls come from the parking lot of the local pharmacy. They went in, didn't know it was going to be that expensive, got outside in their car, started Googling, and called us. So because of that, we make it instant. We can give you that information. You can walk right back in the pharmacy, give them a set of numbers, and they'll run that, come up with a zero copay. We do allow for mailing and faxing. I know that some people don't love to upload things to the internet, which I understand. So we do still allow for that. Our payments can be made via check or EFT. And then again, we do have the portals available for not only applying for new and existing patients, but for uploading claims and documents. That way, if you don't want to fax, you don't have to. I do a lot of these sometimes where I get to the diagnosis and it's closed. So I've got 50-50 here today. Our non-small cell lung cancer is currently closed. It closed recently. That doesn't mean it won't open. As soon as we get funding, we open them back up. But our small cell lung cancer is currently open, which, 50% is a good thing. But so it is, that fund does cover medical insurance premiums. It covers your copay, your co-insurance, your deductibles, the office visits, and it's for $5,000 a year. Again, that's a rolling year. So if you're approved today, if we have funds in a year from now, then you can go ahead and reapply. But yeah, so I know that's a lot of information really quickly. So I'm going to touch on this next one. I will go ahead and preface it with, we don't have anything in lung cancer currently open. that could change, but I want to make everyone aware just because it does change. I highly recommend, if you're able to, sign up for the mailing list. You'll get an email as soon as anything opens. But we do have what we call our financial assistance funds. These are non-medical related assistance. So these handle things like transportation, housing, utilities, different expenses, that normally you wouldn't consider. We had us and American Cancer Society work together recently to have a caregiver fund that assisted with lost wages, respite care, those types of things. But they traditionally cover rent, mortgage, utilities. We have had some for cleaning services in the past, and then just expenses not covered by insurance. So these operate kind of the same way as our copay program, but they don't have as many criteria. Insurance isn't normally an issue because these aren't copays. It's around the same eligibility, about 400 to 500% of the federal poverty guideline. These are smaller grants. They normally range from a couple hundred to 1,000 or so. They do come and go. We work with a lot of nonprofit partners on this because what makes us unique is not, being in a certain disease space. So we do tend to partner with a lot of other nonprofits like American Cancer Society or Livestrong and some others to do some specific financial aid funds. We have some in ovarian cancer with an OCC right now that is helping not only with the cost of getting to treatment, but they also have a fund that we operate that is helping with the cost associated with getting to a clinical trial. And then it's the same application process. It's available online or over the phone, instant decision. And since these aren't a copay pro fund that have a pharmacy card, these are normally come out in check or they come out in prepaid Visa cards, and those are normally sent out next day. I did want to get into a little bit about our community outreach and engagement. So we've been doing some different outreach recently, been at the White House last year, and we've been on a bunch of podcasts. We've been working specifically with breast cancer in some areas. We just put out a short 30-minute documentary about breast cancer in underserved areas around Chicago, which is available on our YouTube channel. I highly recommend it. It's patient stories. It's really, really good, really compelling. We also have our Self-Made Health Network. So this works with the CDC grant support for tobacco and cancer prevention. We work with a lot of state organizations, a lot of community nonprofits to get involved in that. We also have a scholarship program. So this is available to anyone who their secondary education has been affected by a diagnosis. So these are our winners for our 24-25 cohort. We've given over a little over $1 million in scholarships over our time doing it. The applications are open once a year. We have a gala once a year that kind of raises money, but also highlights some of these stories, and some of the kids come around and tell some really incredible stories of how they've overcome an illness to get to where they are, going into college and graduating and even going on to pursue master's degrees and doctorates and things like that. So it's great. We also do some patient-centered research. So this is around patient need. We do, survey work, interviewing patients. We tend to get into the actual issues, not the scientific issues, but kind of the why of it all. So, administrative burden. How long are you spending a week filling out portals or paperwork, or, when you go from one doctor to another, you have to fill out the same documents. Why aren't we able to get on medication? What's the expense look like for that? Are patients coping in other ways? Were you forced to switch to a different medication by your insurance? Things like that. And then we also have a national chapter called National Patient Advocate Foundation. So this is our team in DC, which is not for everyone, but we do policy work at the national level. And we do have a quarterly get together, which we call Policy Consortium. What we do is it's hundreds of patients, providers, pharmacies, nonprofits, anyone involved in the community. They get together and share stories. We distill that down into kind of the main issues facing patients, and then we use it to affect policy change. So on our website, mpaf.org/get-involved. You can sign up to be involved with that. That's kind of it in a nutshell. I know we kind of do a lot of things, and we tend to be in every part of the patient journey. So yeah, please, if you have any questions, if you want me to kind of touch on something a little bit deeper, I'd be happy to do so.